Thank you very much. And now for something completely different. That was such a good first session. I really enjoyed it. So yes, this is the third year that the Phia group is represented. This is actually my first year here. So the speaker for the first 2 years was Adam Russo, the CEO. If you've been here, you know he is a loud talking Polish-American man who will hit you if your phone goes off or if you're typing on it. And I'm totally different than Adam on so many levels. And I was so happy when he asked me to come here and speak to you guys and share my perspective. So I'm going to tell you a little bit about myself and how I kind of got into this market. It's not a normal story. I'm not an attorney. For one, which is unique at Phia. I work with 12 attorneys. I'm also not an American. I'm a Canadian. I live in Canada. So it's so weird, to hear the doc previously share, kind of where things are going, and I'm like, he's talking about Canada, I can relate. I can relate to this. So it's a bit of a weird kind of path into the market. And the other thing is, of course, I'm not a clinician. So I'm not a lawyer and I'm not a clinician. I'm a claims guy. So I experience everything the good doctor previously explained, but from a completely different perspective. Every day I get claims. I look at claims and I process claims. So that's what the only thing I can do is share with you who I am. I'm not going to be very good at pretending I'm somebody else. So that's going to be kind of the way we're going to spend the next little while together. Is I'm going to share with you a little bit about my journey as a Canadian, as a U.S. cost containment expert, and we'll take it from there. And at the end, we'll take questions. So who am I? I am a father of 4 children. I'm married to a marriage therapist. 15 years last Thursday. I'm married, happily married. And thank you. Yes. She's the best thing. And you know what? She's taught me a lot about mental health, and which is, why is everyone laughing? Oh dear, okay. No, but she's a really amazing woman, really opened my mind to the mental health space. So I'm a healthcare cost containment expert. What does that mean? I don't even know. We'll get into that. For the Phia group specifically, I'm a business and product development consultant, and I help them specifically with what we call provider relations. So there's a lot of doctors and ambulatory surgical center owners here and hospitals possibly. I interact with you, so we have a relationship, so I do provider relations. And that's primarily in the form of claim negotiations. We get claims, the employers that the Phia group represents, self-funded employers, have concern over those charges, and we try to engage and interact and really to take big bills and make them smaller is kind of our high-level conceptual goal. And as I said, I'm Canadian. So I was preparing for today's session, and I'm literally like, I'm going to be in front of a bunch of doctors. How am I going to relate to them? And I'm rubbing my chin while I'm doing this, and then I was reminded that I actually had a problem with my chin. I had a cyst lesion kind of growing on it. I played basketball in a men's league, and so I named this sore on my chin Jermaine. That's the name of the guy who gave it to me. He went for a rebound, and I guess my face got in the way. And he's my height, but he's probably got 40 pounds of muscle, 3% body fat. So he just totally almost ripped my head clean off. And then as the weeks that followed, a little sore kind of started growing, and like a little network of caves, and it's like a cyst. It was gross. So I'm rubbing my chin thinking about how I'm going to relate to you guys, and it starts oozing. And I'm like, this is just nasty. And then it occurs to me, I'm going to be in Oklahoma City. I'm a Canadian. I've been waiting 2 months for this surgery. So I have my little letter saying, congratulations, you're covered. 100% coverage, 0 copay, 0 co-insurance, 0 out-of-pocket, 0 access. Awesome. So I'm going to Oklahoma City, and I'm like, I'm going to call Dr. Smith. I'm going to say, we got to do this when I come down for a visit. Put me under the knife. So it was a good plan, really, in theory. It was supposed to happen yesterday. But then American Airlines tried to do a coup to prevent the free market. That's my theory. So I got up yesterday morning at 3:30 a.m. From my home southeast of Montreal, drove to the Montreal airport, and then got stuck in Chicago, and then Oklahoma City, where my luggage was delayed. It was 1:30 a.m. the following day when I got to my hotel. So I'm a little tired, but I made it. And then Keith's like, no problem, we'll book you in the morning. So I got up at 5 this morning, and I went to the Surgery Center of Oklahoma. And Dr. Stephen Richards cut my face, cleaned up the gunk, and re-sewed it. If you want to come see my sutures, I think they're actually very nice. Very nice and clean. So let's go through this. Let's go through the process. Cash, eh? So I emailed Dr. Keith Smith. So he emailed me back. He said, okay, I'm going to put you in touch with my friend who does this, does it very well. I said, fantastic. I was offered a bundled rate, cash rate. So that, of course, involves the professional fees, facility charges, and then the local anesthesia. I think Keith wanted to give me a little cocktail to relax me. I think maybe later tonight if you can hook me up. So I got a flat fee of $800 from a willing seller, folks, a willing seller. And I, as a willing buyer, said yes, and I paid for it this morning, and it's fantastic. I got to tell you, the sore was really annoying. Every time I hugged my wife, I had to lift my chin, because God forbid I actually drop my chin on her shoulder, it explodes, and then she gets something on her Lululemon shirt. I mean, I'll never hear the end of it, right? So I am the embodiment. I just went through, and guess what my claim was? This little MasterCard receipt. It was about this big. Done like that. Over. I'm telling you guys, I was so jacked up when I took a photo. I was like a tourist taking a photo of the surgery center, and really enjoying it. But how simple is that? How simple is that when you can pay for what I needed? And I'm really, really happy to share that story with you and kind of give you a picture that, although we have 100% coverage where I'm from, the access to care is not as great as it could be. It's not as terrible as some of your media folks make it sound, but it's definitely a system that needs work. So what are we going to cover today? Existential crisis. Why do I exist? Now, not why do I exist as a human, but why do I exist as a cost containment expert? Makes me want to barf. Like, what does that even mean? Well, I'll explain it to you a little bit. Why network contracts suck even when they don't. So I speak from an employer perspective, and I'll explain to you a little bit about some of the encumbrances that we see with some of the contracts. And not only with the contracts do exactly what they were meant to do, but it's what people want to do with them in addition to the contracts. They basically want to violate their contracts, which is a big problem. I'm going to talk to you about the weird world of auditing claims. People who take claims and say, hey, did you actually do that? I want to pay less money. I'll talk to you a little bit about the implant wars, implant charges. Employers really don't like high markups on implants. I'll discuss that a little bit. Talk a bit about the game of negotiating, what it's kind of devolved to or what it always has been. Best and worst laid plans, that's plan documents. You down with RBP? That's reference-based pricing. I do a little bit of work in reference-based pricing, so I'll explain to you my experiences there. And then finally, I'll talk a little bit about cash is king and how high deductible health plans are growing and how there's an emerging cash economy that's kind of coming into play. All right, so why do I exist? I exist because there's crazy claims out there. We had a claim, $360,000 for bilateral cochlear implantation. They were charging $60,000 per cochlear implant. But don't worry, folks, there was a 20% discount. So yeah, the employer was mad about that, and then they wanted some help. $25,000 tonsillectomy, that was a good one. $152,000 shoulder scope. $180K appy. My previous record was $142. I had to update my slide because I got one out of California. And if you work in the claim space, it's kind of, have you ever hung out with people that have really extravagant lifestyles? So you say, hey, I went to the lake and we rented a cabin or whatever. Oh yeah, that reminds me of when I went to the Hamptons. You know, they always have a one-up story. The claims people are notorious for this. They always tell you their worst story. Oh, I got one worse than that. Well, I heard one recently. I was talking to a friend about urinalysis for addiction centers, and so we were being billed about $5,000 per urine test, which is, guys. And then he goes, of course, one-upmanship. He goes, I have one for $20,000 per urine test. So it's just kind of nuts out there. And to quote Dr. Gerard Anderson, it's the price is stupid. You know, why the U.S. is different, is so different from other countries. There is a lot of high charges out there that we're asked to address and engage with. So lottery pricing, this is for treatment of pulmonary obstruction, and it's hard to see from the slide, but if you get that care at Lincoln Medical, you'll pay about $7,000, and if you get it at Bayonne, you're looking about $99,000. So just radically incoherent, illogical, inconsistent charges in various markets, and that makes that causes a lot of problems as people try to select value in their healthcare. So here's a quote from a hospital system. We acknowledge that we've had a historically high charge structure. It does not mean, however, that we're receiving high or unreasonable payments from consumers or insurers. The CMS report, which of course this is what they're commenting on, focuses on charges and not the more meaningful payment data. And so there's, from the provider community, there seems to be this, hey, whoa, we get it, we get our charges are high, but it's not what we actually get paid, so back off. Okay. Here's another quote. The biggest misconception is that hospitals are charging too much to rip off consumers. I can't think of anyone that is happy with the current pricing mechanism. We'd like it to be simpler and more transparent. Then why are you charging too much? Oh, we are charging too much, but it's not to rip off consumers. Guys, if you're not confused, you don't know what's going on in U.S. healthcare, as far as I'm concerned. So why do I exist? So despite the rhetoric, and there is rhetoric out there about everyone trying to do the right thing relative to charges, no. There are a lot of people out there who are predatorily just exploiting as much as they can. I've got a story about, I was working on a claim, $1.7 million. It was a reference-based pricing plan. So instead of having a contract, they just hardwire in the plan document what they're going to pay, and they said 150% of Medicare, which, say what you want about Medicare, it's at least something that isn't charges. So in this world of extremes, they picked a benchmark. So it was going to be about $490,000 on 1.7 million, which says, I think, a little bit more about the charge structure than the low amount. And we could tell that was in line with average commercial rates. So with my data specs, I can carve out Medicare and Medicaid from what is actually reimbursed, and then take an actual spec on average commercial reimbursement. And it was right around that mark, because a number is just a number. It can coincide with another benchmark if 150% Medicare, makes you nauseous. So the lady we were talking to, we were trying to find a cooperative agreement. It's always our goal to reach out to the provider community and say, hey, what can we do to get a signed agreement, and so that there's no misunderstanding, that can work out a deal cooperatively, and that certainly there's no balance billing. This specific provider said, no, I will not negotiate with you on this. And I'll never forget what she said. She goes, it will be my pleasure to balance bill the member. I'm thinking, $1.2 million? Like, I get it. It's my policy to balance bill. It's my obligation to balance bill. But this hateful human being said it would be my pleasure to balance bill. Shame on you. I'm sorry. That is disgusting. And I meet a lot of people like that. Unfortunately, I meet more people that are good, but I have to highlight a bit of drama. This is a presentation. I want you to be engaged. So I am the manifestation, I am the physical, living, breathing manifestation of a market in dire need of correction. Stated otherwise, I had an American client, actually, it was Jay Kempton last year. He said, oh, you're going to meet a lot of people, they're trolls, and if they can't tell you what they do in the system in 10 seconds or less, they're probably a troll. So I took that challenge really seriously. I was like, am I a troll? I'm like, I might be a bit of a troll. I'm an intermediary that doesn't really add value. I just move decimal points, you know. But I'm a troll with a soul. And if I had to say what I do, I had to explain it once to someone. I said, I limit the amount that employers get screwed on their healthcare. That's pretty much not exactly something I want to put on my epitaph. But that is currently what I do. But I work with the Phia group. Phia is a self-funded employer group. And if you know Adam at all, we are so engaged in trying to communicate, educate the employee base to make smarter choices. So we are trying to find real solutions to the underlying problems and not just be the Band-Aid on a claim-by-claim basis. And I hope I've proven by getting my own face chopped this morning that I am personally engaged and I do care. How could I not care? Healthcare touches us all. I'm sure we can think of situations when people that we love needed it. And when you need healthcare, nothing's more important. It's like breathing. So it's a big deal. I take it very seriously. All right, so why do I love my job? You know, it really changes a lot. Every claim's a mystery. I have to dissect and look at what's going on and what resource centers I have to bring in. Do I have to bring in some clinical resource centers? Do I have to bring in some legal resource centers, coding, financial benchmarking? I kind of like that. It's fun. I won't miss it if it's gone, though, so you might want to work on that. I do meet really good people who are as confused as I am, but from their own perspective. I'm really looking forward to hearing more from the docs and how they view this crazy market. I'm bringing my very narrow claims view, but this is all about expanding our perceptions, and like Dr. Keith said last year, it's all about changing minds. The power of changing mindsets is what the FMMA, I think, really does well. And in an unprecedented manner, I think we're seeing innovation. The very fact that I am traveling from my country to get work done is crazy. I think the more deductibles that are out there, people are doing some fancy things, but it's on the fringes. But I hope we do see, as someone mentioned earlier, a tipping point where we can see more of the free market principles in play. So why I sometimes hate my job. Have you guys ever seen Monty Python, Search for Holy Grail? I swear I'm that guy. Bring out your dead. Bring out dead. I mean, I'm talking claims here. The worst claims you could ever imagine. Clients are coming to us saying, "Oh, I got this claim. It's with Blue Cross, United, Cigna. No, oh man, it's too much. I want you to get me less." I'm like, "But you contracted with them for that rate." "Yeah, it's too much. I want more." Hey, what could be easier? Going against Mammoth Health System and a Mammoth network. No problem. I'll just flash my Canadian charm and get a signed agreement. All right. "Oh, I paid this egregious bill in full. Can you get my money back?" Yeah, that's easy to do. Oh, this is a good one. "A dirty vendor tricked me and I'm getting sued. Can you help me?" There's a lot of weird people out there selling all sorts of weird stuff. And we get the blowback from that. We try to help out the employers. "Oh, this is good. I have terrible plan language. Can you help me get a deal with this egregious provider?" So the importance of articulating your rights in an employer-sponsored health plan is critical, and it's still something that people kind of underappreciate when you go to execute on articulating your rights. Oh, I forgot about this one. That was a late addition. "I sometimes hate my job because I have negative interactions with the provider community." So I've been going back and forth whether I should say this story. I'm just going to say it. We're going to have some fun. So the worst thing I was ever called, I was on the phone with the billing rep, and we're trying to hammer out a deal, and I try to be polite, but I'm a human being, and maybe that day I had an extra coffee, I didn't sleep well the night before, who knows, maybe I was being a little cantankerous, I'm not sure. And the doctor got on the phone and ripped the strip off me, and he's like, "Am I going to have to go through a prostitute to get paid on this one?" So he was calling me a prostitute. He didn't call me a prostitute, he picked another word. So I do have sometimes very adversarial conversations because you are trying to do your job, but there's another perspective on the other side, and sometimes that's not so fun. So that's why I sometimes hate my job. So now I'm going to walk you through kind of 3 or 4 major hubs in what I do that affect pretty much every day my world. And we're going to start with the networks. So whatever your network contract says the alternate rate is or the repriced rate is, that's probably what you're going to have to pay. And I know that's a simple thing, but like I've said, a lot of employers sign these contracts or engage in these contracts, and then they see a claim and they're like, I don't think my contract should apply on that because it's not fair. Okay. So we try to help them out, and of course I work with lawyers, and we read agreements, we read contracts, we try to look for soft spots to try to articulate, hey, you do have rights. So we had a PPO agreement contract, and it actually had good language. The PPO contract in this case said, hey, a plan is only subject to that agreement, the network agreement, as long as the benefits have not been exhausted. And so the plan was like, oh, that's not normal language in a PPO agreement. We're going to argue that the plan has a maximum allowable, and so there are no benefits past that maximum allowable, and therefore it's not those additional charges, those excessive charges, are not subject to the terms of the agreement. And in this case, the plan actually had really good plan language that had a very well articulated kind of maximum allowable, usual and customary. And so we presented that to the provider and tried to get a settlement with them, which they did not agree to. There was a 10% in-network discount on a wildly inflated claim. And so the plan was like, you know what, I'm just going to pay and we'll deal with it through the appeals. So the plan paid a reasonable payment. I think in this case it was about 200% Medicare on that payment. So I don't know where you land on how you view Medicare, but Medicare, I get it. Maybe that underpays. Twice Medicare, is that okay? The plan in this case thought it was. And so they received confirmation that the hospital had cashed payment and that the account was at zero. So, hey, good job, good job, good job, good job. Everyone's happy. But not so quick. Many months later, the provider did appeal. And so the plan defended what they said and then said, hey, well, we relied on you cashing and writing off the balance. The provider, since then, has filed a lawsuit, which we're working on. And I guess the bottom line is, network contracts are really designed to be followed, and kind of the slogan I always say to myself is, when is a deal not a deal? And I think a lot of employers, they want the access to a multitude of providers. They want the safety that the networks bring, but they're starting to see when things are a little out of balance, and they want to start carving things out. But the act of carving things out of a network contract is a violation of that contract. So you have to get those things approved by whoever you're working with, or else you're going to be in a world of trouble, and there's not much that we can do to help out. So the whole network dynamic is a challenging one. And some payers are actually responding by abandoning all networks, which is very controversial. I think probably the more prudent approach is to try to do more, try to engage with your partners, carve out some things, try to get some of those high value options, and take it from there. But this is a day. I would say 9 out of 10 issues that are brought to Phia on a daily basis are related to someone wanting to get out of what they've already agreed to. And that just has to stop. We have to find a better solution. So the odd world of audits. Now I'm going to talk a little bit about how people try to save money on their claims using claim audits. And it'll explain to you a bit of the complexity tied to audits. So the king of audits, of course, is Medicare and Medicaid. And in 2013, RAC auditors found $4 billion in mistakes. Pretty awesome, right? Not really, when you consider that that's 1% of what Medicare pays out. So the biggest auditor with the biggest budget, regulation, policies, the whole 9 yards to help audits, they get 1%. And what's interesting is the private market tries to use audits, but they're trying to save like 40 to 50% at a time on claims using audit logic. And I'll walk you through what we see. It's a little bit spooky. So first of all, does your plan language even allow you to audit claims? Half the time, it really doesn't. Which again, the Phia group, we write plan docs for people. So we're like, hey, you've got a problem, you want rights, you want to be able to tell someone you've got a problem, make sure you articulate it in the plan language. Probably the biggest thing is the PPO contract doesn't allow you to audit the claim, and so they're doing something that even the agreement doesn't allow. What does the facility audit policy say? So facilities themselves say, yeah, you can audit, but we have an order to things. You can't just willy-nilly do it, which I can understand, you know, the opposite perspective, like, well, I'm auditing your mistakes, so why are you dictating the rules? But it still has to be an orderly way to do it. And then there's on-site versus desktop. I've seen desktop audits done. This is where you collect all the information and then you sort of from your ivory tower dictate what was right and wrong. Or you go on site, which seems to be the only place you can get a complete medical record anyway, and then you interact with someone from the hospital and get the findings. I think the on-site has shown to be a little bit more kind of stable. We've seen better luck with that. And then, of course, if you're going to do a desktop audit and unilaterally to reduce a claim, you are exposing the member potentially to balance billing, which is a big concern. So the basis for the audit, you know, I think a lot of people think that there's this magical law of how to bill and that, you know, we all have to follow these guidelines. But there really does not seem to be any guidelines. I think there's industry practices and best practices. But, you know, charge masters can range from 12,000 items to 45,000 items, depending on what you consider a billable item or what you've grouped or non-grouped. And even, you know, Medicare, the Center for Medicare and Medicaid Services has said, hey, while the Medicare program can decide, you know, the Medicare program cannot dictate to a provider what its charges or charge structure may be. The program may determine whether or not charges are allowable under their cost apportionment platform. So that's really what Medicare's like, hey, I'll decide whether that's part of my DRG calculation on the weight of the cost with the outliers, with the grouped, you know, diagnosis codes. I can do that, but I can't tell you how to charge. You know, that's really up to you. And so, you know, it comes down really to bundling and unbundling. And so one hospital might include charges in a room fee, whereas another one might say, well, I'm going to unbundle those. Those are going to be billed only if they're used. And the truth is that payers don't seem to like either practice. If you bundle it, oh, well, did you actually use it? Am I paying for something that's defaulted and wasn't used but charged? Oh, you unbundled it. Well, that really should be included. I shouldn't have to pay for that. The bottom line is payers are so mad about the prices that they're trying to find any reason to not pay the claim. It is really kind of a messy world out there. So here's a good audit, an audit I was part of. So $1.3 million claim. There was 900,000 of it was for the bill charges for an MS drug. And it was in network. The claim had gone to 2 other vendors. And we were looking at it, and it passed every audit you can imagine. So the units were right. It's just that the price looked wrong, which of course is a self-serving comment, trying to reduce the claim. So I was dealing with the lady at the hospital, and I'm like, you know, do me a favor, go down to the packaging level. Just go down to the packaging level and just confirm that the packaging with those units is right. I said, because even per your own markup ratios, because I know how much they mark up generally over cost for drugs, and it was way out of whack. Like usually low-cost drugs have high markup ratios. High-cost drugs have lower. It's kind of on a spectrum, right? Because, you know, there's a certain yield of revenue off that markup. And it was way out in the stratosphere in terms, it was almost like a Tylenol markup being applied on one of their highest cost drugs. I said, you've got to go down to the packaging level. And so she did, and I'll never forget the email I got. So it was shown that they were actually billing 30 injections a day. So they were charging for a box. So you were getting the case of beer, you know, you're being billed the case of beer instead of, you know, the King can or whatever. Why did I use a beer analogy? Oh, I just set back Canadian-American relations for 20 years. What was kind of interesting about that is that the provider was so embarrassed because it had gone through 2 other vendors that they actually paid the fee for the audit, which was, I've never had that happen, which was interesting. So an audit is pretty basic. Hey, did you do this? You know, it looks like you never did it, so I don't want to pay for that. You know, it's pretty valid. I don't want to pay for something that didn't happen. Or, hey, it looks like you inadvertently harmed a patient during care. You know, I want to carve out some of that liability. I think that's reasonable. And I think working with a professional, there's a lot of hacks out there. Work with a professional if you're going to use this approach. It's always the advice we give to our employers. And then, of course, try to use the audit findings for a resolution. Get it signed off, put it to bed forever, and that'll work. But the audit space is very contentious, and it's really a market. If you think of how inefficient it is to review thousands and thousands of lines of charges to try to get a few points off, there's a lot of machination there that really yields very little. And then finally, you know, correlation versus causation. I think a lot of people think that there's this secret society of people who know how to bill right, and that if you present it to them, they'll be like, "Oh, you got me." It just doesn't work off that way. A lot of providers get paid less than they expect, and they'll write off those charges just because they don't have time to chase after every short payment. And so that actually reinforces the audit community to keep doing what they're doing, and there's really not a solid basis for it. It is. Oh, and lastly, a lot of the audits don't actually carve out what was done and not done. What they'll do is they'll just reprice lines to, oh, well, you overcharged me for that line. I don't disagree that you didn't bill it. I just think you overcharged for it. So it's just another way to adjust the pricing as opposed to the scientific basis of validating charges. All right, so that concludes audits. Now is implants. One thing employers, when they look at a claim, they can't tell anything when they look at it. And so they have a tendency to harness or focus on one charge. And implants are usually that charge. What? Ref code 278. I see that charge. I know it's overbilled and I've got a problem with it. And a lot of this is in the field of orthopedics. We are seeing some really ghastly claims for implant markups. And of course, we have seen, of course, a growth of procedures, and that means more implant claims and more upset employers. In terms of implant costs, I mean, these things can really range all over the place. I found some data on hip implant costs. So to build a hip implant might cost you $350, but by the time you get it to where it's been distributed and repackaged and marketed, you know, you're probably looking at an acquisition range of $4,500, $7,500. And we've actually seen at the Phia Group a hip implant billed at $60,000. Just absolutely, there's so much money being made in that industry that the employers really have a hard time stomaching some of these charges. Well, it's good to know I didn't get a chin implant this morning, but had I gotten one, Dr. Keith would not have marked it up. I won't read the quote, but that's essentially, I asked Dr. Smith to tell me, well, what's your position on markups? And he's like, well, we don't do it, and we don't think it's right. There's really on consignment here, and this is really part of this market that really tries to get away with charging more than what is reasonable, and I can appreciate that sentiment. I personally have no problem paying a percentage above cost, but when it's like multiples and multiples of cost, that's something that kind of bugs me and certainly bugs the employer communities we represent. Oh, here's a new one. I'll never forget this one. Okay, so employers are always trying to pay a percentage of the implant costs. So they want the implant invoice. If you talk to any, we're pending the claim for the invoice. We're pending the claim for the invoice. They're always pending the claim for the invoice. So some enterprising person said, hey, you know what? Let the ambulatory surgical centers bill for the surgery, and then we'll bill separately for the implants as the supplier invoice. So we actually got a claim for a knee replacement. There are no implant charges on it. So we're like, oh, what's going on? Then we finally got a separate claim from the implant supplier showing you the implant invoice. But all it was the markup applied on a separate invoice to make it look like it was the cost invoice. So of course we had to set that straight and get a deal, which we did. The other thing, of course, is that implant-specific provisions in a plan document is something that we do tell our clients they should probably consider. And you know, some folks are not comfortable sending us their implant invoices. Maybe they don't have them. Yeah, right. But we do ask for the implant log. And so with my team and our financial benchmarks, we can actually determine the acquisition costs for those implants. And we try to approach the provider community politely. Hopefully I don't get called any nasty names, to try to get them to engage and do a fair price on those lines. So just a quick case study on an implant. Double knee, billed at 91. Client had a history of 10%, again, 10% across the board. Just by carving out the implants and saying, okay, we're going to do the implants at a cost plus, you know, and then, you know, we'll apply the 10 on the rest if you want. Really had a positive outcome on the net payment. Really, it's one of those charges that greatly inflates the claim, and it's an area of focus for a lot of providers. All right. The game. So the game is the whole prepayment negotiation side. I hope you guys start feeling what I do on a day-to-day basis. I get a claim, it's covered, but it's not paid, and then we have to try to call providers to try to get a deal. And there's more attorneys involved now for the hospitals. We call half the time, we have to talk to an attorney. And a lot of providers now are getting wise. It's interesting that the Phia group have always said, hey, make sure your plan doc protects you. Now providers are saying, well, what does your plan doc say? So I literally had a provider the other day say, send me the plan doc. And they're like, oh, based on that plan doc, we think we can recover this. So they literally are looking at how much can I exploit from how you've designed your benefit structure, which in some ways I suppose makes sense, but it's really, the game has totally evolved from people knowing exactly what they can do, and they're trying to exploit from a formula of their charges how much they can recover. And I think what we often face is situations where, you know, what do we do when the provider, the plan, so I often get, and here's the example, I often get situations where my client goes, get a deal, Jason, just get me a deal. But then the provider doesn't want a deal, or the deal is terrible. And so I had a case recently where I was talking with, and this was my $152,000 shoulder scope. 20%. I mean, I'm talking to the rep, and I'm like, you got to be joking. And she's like, you know, I'm talking to her, and you know, she's really nice, and maybe not the most, you know, bright gal, but she lets out the secret. She's like, you know, if you just pay us, she goes, we'll appeal, and then you just send us your final offer, and we'll accept it. Guys, I'm a healthcare cost containment expert. And so that's what I did. Not exactly huge acumen or skill, not Dr. Richard's sweet suturing. I mean, this is as dumb as it gets. Oh yeah, just pay us something, we'll appeal it, and then make us a final offer we accept no matter what it is. Because they've calculated that on average, when they put their foot down at a 20% max, most employers who really love their employees would never allow them to be balance billed. And so the credit of the patient, or the perceived threat to the credit of the patient, is the ransom that feeds this vicious charge cycle. It's really, that's the game. That's why when the Free Market Medical Association says, remove all intermediaries that don't add value, this is exactly the kind of garbage and junk, as Jay said, that needs to be purged from the system. And I have no issues altering my career path to not do that anymore. Seriously, I mean, sorry, I have a tendency to do this sometimes where I just talk through this. Okay, so best and worst laid plans. This is just plan language that we see that describes what the plan's going to pay. So awful is obviously we'll pay off of provider charges, so you're really setting yourself up. Might as well just send out some blank checks while you're at it. Typical is we'll pay based on usual and customary charges. So whatever the average provider charges, we'll pay, you know, some type of percentile on that. I'm not a big fan of that. I remember calling one provider whose practice was they would buy the UCR database from whatever database suppliers out there. You probably know who they are. And they would bill 2 times the 90th percentile, and then would offer 50% discounts, which of course is like collecting full bill charges at the 90th percentile, you know, and giving a discount. And the other thing they told me is like, yeah, we like doing it that way because provider charges are always taken on a snapshot, so the following year when they do a snapshot on our charges, it's always twice what it was on the 90th percentile, and so the next rolling snapshot of next year's UCR is going to be higher. So yeah, the average percentile of unregulated, not that regulating charges is something, but that a market can somehow measure or counteract charges is not a good language. Better language is, you know, what's typically accepted. You know, I think most employers don't want to get a special deal. They just don't want to pay a lot more than the average. And so paying what the average payment or reimbursement is something that a lot of folks put in their plan docs. And then finally, you know, probably for the best from a pure savings point of view is to have a negotiated rate, which can be anything, or Medicare rates or some other benchmarks. And there's a ton of benchmarks, cost, which is derived from Medicare. It might as well just be called Medicare. But something tangible that you can work with. So we had a claim in New York and almost $500,000. And the language was what we called better. So it was what providers typically accept. And so what we did, and I know DRGs have been maligned, but I use them all the time as a benchmark to reduce cost. And so what we did is we did a DRG. We priced a DRG for all the facilities in the 25-mile radius. And then we crosswalked the DRG reimbursement to their average commercial reimbursement. So I mentioned to you before, I can actually take a hospital's financials, purge out the Medicare, Medicaid, or otherwise public payer reimbursements, and then derive an average commercial reimbursement. So I crosswalked all of those DRGs to that commercial re, and it came to 134% on average was the average commercial re for the radius. Presented all that data to the hospital, and you know what? Kudos on them, I think. They accepted, and it was a payment of $182,000. Again, we're not trying to just say haggle and pay less than what was billed. We're trying to use science, trying to do it right. Again, it's kind of part of that intermediary phase, but this is how we do it. I just want to show you guys what generally I do. Reference-based pricing. Okay, so I mentioned before that networks are sometimes perceived as a barrier to what the employer ultimately wants, which is savings on certain claim types. So I think networks do a decent job across the board, access, general savings. But on certain claims, they can be, you know, there can be some difficulties reconciling what value is. And so reference-based pricers will literally say, I'm paying a percentage of Medicare, and they have no networks, which is controversial, very controversial. I heard one person call it inelegant. It is inelegant. Although, in their defense, we have an inelegant problem. And so it's probably an inelegant solution for an inelegant problem. So I worked some claims for reference-based pricing, and I worked some on the traditional side. And in 1 week, I remember I had claim at the same hospital. One was with a reference-based pricing plan, and one was with a traditional plan. So for the reference-based pricing one, which was the bigger of the two, we were able to close that one for a total payment of $297. And on the traditional one, we got, which was $400,000, we had a total payment of $320, or 20% discount. We have no leverage in a traditional platform. We do have a lot of leverage, because how are you going to collect, you know, $1 million from a consumer? It's just, it strains credulity, right? And so, you know, we have seen that type of tactic work pretty well. One advantage to not having in the reference-based pricing is that it does allow open use of cash accepting providers, because there's no encumbrances from other agreements, other commitments expressed in a contract. And again, I'm really torn on that. I've seen the good and I've seen the awful from the applications of some of those strategies. But you know, I think you guys are well served to know about it. And then finally, cash, a game changer. You know, we recently at the Phia group had a situation where we had a procedure, and it's going to be pretty high cost. So the charges were going to be about 60. The in-network rate was 30. We managed to call and get just the same surgeon, but switch to a cash accepting facility, which was actually better. And we got a cash payment of $10,000. It was just, you should have seen Adam. He was just so pumped, you know, and there's just so much that can be done. And even after today, my perspective, you know, you talk about stuff, you're kind of a trend watcher and you talk about it. Now that I've actually done it, I've physically done it, paid for it, it's really easy. It can be done. It's just member education, and that's really where I'm going to wind down is with the members. So high deductible health plans, probably in my opinion, the biggest trend that people don't talk a lot about is how fast your out-of-pocket responsibilities have cranked up. I'm kind of a fan of the higher out-of-pocket. I think if I were down here as a citizen, I would want a high deductible health plan. Of course, I would anticipate and have, you know, maybe in an HSA build that out. But it's hard to imagine that some folks have not, either don't understand or have not prepared for their out-of-pocket responsibilities, and so there's a lot of lingering stuff out there. It's kind of spooky. Some of the stats I'm seeing, it's trying to collect some of these out-of-pockets. You know, just forget it. The stats are sub 50 at best. And then it's on a spectrum, right? So I think if it goes over, I think the average current deductible is about $1,300, which I think is the minimum standard according to an HSA qualified high deductible health plan. 10 years ago, it was $584, so it's definitely grown a lot. And there's a lot of out-of-pocket spending, $345 billion. That's a ton. That's a ton of money going out there. And then the question is, does it actually save money? It does. A lot of the stats have said between 10 and 20%, the higher you jack up the deductibles, the more you'll save money. But it's not because the consumers are all of a sudden really engaged. Now, I think that makes sense, but it hasn't been proven. A JAMA study said people with higher deductibles were actually not more likely to shop around for their health care. And another study from the National Bureau of Economics Research said that people had a tendency to avoid all care altogether just because they were confused. When people are confused, they have a tendency to just, okay, I'm not going to do anything. I'm scared. I'm just going to put the brakes. And that's kind of some scary stats. I think that as that market evolves, educating the consumer, giving them the right tools so that they can spend their deductible wisely, keep cranking up that amount so that they're personally responsible, so that moral hazard is kind of reduced, I think is part of the solution. So thoughts for the road, guys. FMMA is growing, but the status quo still reigns supreme. I feel like we're still kind of decimal dust in the grand scheme of things. I hope that changes. I think it'll change with high deductibles. I think when we see higher deductibles kind of become even more mainstream, which, you know, the talking heads have said it's going to happen. We'll see. Employers are really kind of ticked off, and that's a good thing. I think they're looking for people like you. They're looking for partners to drive value. Of course, the employers, whatever they do, have to make sure they're compliant and put in their plan doc, brought to you by the Phia group. Networks try to control, but I find that a lot of good networks are really diversifying what they're doing and trying to embody. Some of the good ones are trying to embody you guys. So, definitely engage in some of those dialogues with them. And a lot of the other interventions, like ACOs, have not really shown a ton of promise yet. I'm not saying they won't, but there's a lot of room for something that actually works, and I think cash payments is really part of that. So reference-based pricing, although inelegant, is out there and is growing and pushing the boundaries, and there's some opportunities that they bring with them. And finally, ultimately, the cash payments brings transparency, and transparency is goal number one. If we can achieve transparency, the rest will flow more or less well. Guys, I want to thank you so much. That's really it that I have, but I'll take questions if you're interested. Yes.
Okay, so is there any case law, against these that ultimately go to court? Has any of that been established on balance billing discrepancies?
Great question. Yeah, so most of the case law, as I understand it, and I'm not an attorney, disclaimer, is that where there is a contract, obviously you cannot balance bill. And where people have tried to subvert their contract, I don't think the courts have been too permissive on that. When is a deal not a deal? That it would take something kind of a smoking gun in the claim environment to really justify that that behavior. Kind of one of the more interesting things that's happened is, so in many ways I find that ASCs are great because they challenge kind of the larger health systems and bring some competition. Some of the worst claims we get are from ASCs that actually seem to poach patients, tell them that they'll waive their deductible, and then they send these ginormous claims through to their insurer. And there was a lawsuit in California, I think it was Aetna versus Bay Area Surgical Management, where basically they said, by routinely waiving the deductible, what they were doing is inflating the claim, which is insurance fraud. No different than if you were getting a roofing quote and they kind of bake in your deductible. So they won, and so that's kind of been I think an eye-opening precedence as it relates to charges. In terms of balance billing, of course, there's the federal law regarding how much you can balance bill if a member, for ER, if a member qualifies for financial assistance. It's the whole if they apply for financial assistance. So it's a step in the right direction for the not-for-profits to not balance bill, but we have not seen at the street level anything really materialize of much substance of providers really changing their practices. They have changed some of their practices, but there's still a lot of balance billing out there.
We're going to do this.
Thank you. Really, really great talk. One issue that we've run into when we're going out and reaching out to employers, and I think a lot of your sample claims highlighted this, we're talking, if you look at what's happening in the free market world with direct primary care and cash-only surgery centers, we're looking at $10,000, $15,000 of savings per healthcare event. And you're showing claims where you're saving, you're negotiating a $1.2 million claim down to $300,000. So when we're talking to employers, they're saying, this is great. Yeah, you could save me 20%, but this is not where my healthcare costs are. My healthcare costs are in the, $1.2 million liver transplant I had to pay for. What is your advice in terms of applying free market principles in addressing these higher price claims, which are really what are going to motivate the employers to make the shift?
Yeah, I think the big win for the employers is once you truly educate and engage a consumer at the lower dollar amounts. So if you have under a bronze plan where you're looking at out-of-pocket deductible of $6,100, it's a lot of money. And I think some people are worried that once that consumers see the deductible as that goal to burn through so that they can get their free care. $6,100 is a pretty big goal. I think it is effective at keeping keeping folks engaged. I think the big win is if you can use direct primary care and cash payments as an engagement strategy so that the member is totally engaged at that level. Maybe you can set up scenarios, and I'm sure there's a lot of great vendors out in the audience or programs, maybe with gamification strategies where you sustain that engagement through the higher dollar claims as well. But to overlook the primary care functionality and the value there, there's not only a huge financial benefit, I think there's a huge administrative benefit because that's where the higher volume of transactional volume is. And so if you can simplify the transactional process as well, that's a big win, I think, for employers and their administrators.
Thank you.
Just a quick comment, and I might be somewhat biased since I am a physician, but the study you quoted about the buyer of medical goods and services is not influenced by whether it's free or whether it's covered. They just go wherever they're told. But who tells them to go? in this room, there's probably some businesses who are beginning to tell their people, I want you to go here because that's where it's more cost effective. But I think also physicians play a huge role. If we are involved in this process, patients trust us. If I say, I know this cardiologist, I think you should go there, they're probably going to want to go there. And so I think that's a big key there. Specifically, primary care is somewhat of the gatekeeper. And in my experience, there's not enough primary care doctors really fighting this fight for their patients. But that's because the status quo still reigns as king, and hopefully we're all changing that some. But if you get that involved on the smaller level, it makes a difference on the higher level because of that trust, that rapport that the patient/employee has with their doctors.
I totally agree. I think that's a lot with what Doug was talking about earlier. Maybe the one study that I've read that makes me wonder how it's going to shake out is just how the millennials look at the physician relationship as being very transactional, and that loyalty and trust, things that we've said, I think I heard at the conference. I listened to all the sessions from the last 2 years, and there was a lot of this talk of trust. It'd be very interesting to see how a millennial, or, renegade kind of runs through that process and what their consumer behaviors are. That's to be determined. Hi.
Our local hospital just recently joined up with some surgeons to build a surgery center, and I became aware of a practice that they have. They have some sort of a contract with Blue Cross. For example, if a patient comes in, has $10,000 worth of care, they have a 20% deductible. They get billed, they pay their 20%, and they receive the other contracted rate from Blue Cross. Then 30 days later, Blue Cross gets a rebate of $4,000, which the patient is not aware of. This is evidently something that's been established between the hospital and Blue Cross. Sounds a little fishy to me. Have you heard of this sort of thing before, a rebate?
I mean, yes. I would prefer not to comment on that one, just because I work with lawyers, that you can make it legal. Does it sound ethical? I'd rather have one of my attorneys engage that question.
The patient's deductible is more than 20% at the end of the day.
Oh yeah,
They don't know it.
No, but it's more, so it's the rebate, so the facility rebates back to
Blue Cross. At the end of the month, they write a big check back to Blue Cross for a percentage of what Blue Cross has paid.
Yeah, that's inherently inefficient, I don't know.
Okay.
If nothing else.
Just wondered.
I'll bring that one back, and we'll talk later, and I'll see if I can't get something more solid on a response there. Guys, thank you so much.